here today, and why does COBRA exist other than you had nothing better to do on a Monday night?
COBRA exists because you would not stop annoying me a couple of years ago during the pandemic, and I needed somehow to channel your energy.
Nice.
Really, we started this because we had such great faculty who were awesome educators, and we thought we'd just do something that's mainly geared for the fellows. And we realized our fellows are our best teachers. We all learn a lot, and I think we're going to learn a lot this season. So how about we get started? Sound good?
Sounds great. So I think we're going to start with a first-year fellow from the Cole Eye Institute. Want to introduce?
Yeah, we have Ferris Santaki. Ferris is our first year fellow. I did his medical school at McGill, did his residency at University of Montreal, and then spent a year over in London working with Pierce Keen and the machine learning artificial intelligence group there. We're lucky to have him. Ferris is going to show us his first case. Ferris, take it away.
Thank you very much for the introduction. It's a real pleasure to be here. Last time I was here, I was still applying. So attend COBRA. It's useful.
It might get you into fellowship. Is that what you're trying to say? Nice plug. Good job.
Maybe. All right. Can you see my black screen?
Yes.
Perfect. So this is a case. It is really, simple basics case of hyaloid lifting and ILM peeling in a patient. We operated with Dr. Rachitskaya for a full thickness macular hole. But the idea of presenting this case kind of early on here is just to, show basically what I was thinking as a trainee and the things I was looking at as I was operating, a little bit of introspection as I rewatched this video, and then have the opinions of our faculty here to also get their point of view at what they're thinking as I was doing the things I was doing. So some parts of the video are sped up on purpose, and then some are live, real time. So we had a 66-year-old female referred for macular hole. She had a history of LASIK in both eyes, 1+NS, 20/50 VA, visual acuity in that eye. She had some peripheral pathology, lattice and atrophic holes, and then had the full thickness macular hole with VMT. So we're doing this case under MAC with subtenon block. I'm operating here. This is 8-time speed. So we start with subtenon block, then trocar insertion. I'm marking twice. I'm not sure why.
Better be safe than sorry.
Yeah. This is a phakic eye. We're clearing the ports. Then we inject analog using a reflux technique. So we turn the cutter off, we aspirate from the 10 milliliter syringe, and then we reflux it back into the eye. Here I'm trying to do the PVD, but this is sped up because I have another portion that is live. So I attempt a bit, then we decide, let's restain, because the nasal part, I wasn't able to see a good view. Here, this is in real time. What I'm thinking at this moment is I've tried to induce PVD a few days before, but I was pulling up too quickly. And then here I'm thinking stay low and be slow if you want to, be successful at this. Let's ask
so
maybe
Dr. Talcott. So whenever the cutter sits so close to the retina, it makes me feel like so comfortable as the attending. So he's obviously going to show us like some amazing work, and this is right in the first part of his fellowship. What are some of the tricks to this? Did the staining pattern tell you how to guide where the cutter needs to be? What if it was a more diffuse pattern? Any thoughts on how to teach that first point?
Yeah, I think those are both. I think that's a good question. So as nervous as I am about the cutter being so close to the retina, I find that our first year fellows are equally as nervous about being so close to the retina. So they'll often, when they're trying to lift hyaloid, go down, think that they're close to the nerve, but they're nowhere close to the nerve, and then just aspirate a little bit and come right off of it. And if you do that, you're going to be unsuccessful at getting to lift the hyaloid. So what I try and do when I'm doing this is I actually mag in quite a lot. And then I'm paying attention to the shadow of my cutter to be able to tell sort of how close I am to the retina. I usually start with my mouth out either towards 12 o'clock or 6 o'clock. The catalog can be helpful to see where the edge is, but sometimes you just kind of need to, oh, it's our first technical difficulty of this COBRA year. um, either go, either go towards 12 or 6 and just kind of trust the process, because sometimes the visualization, even if you put catalog in, is not perfect.
Perfect. So
this is beautiful, showing the skidic nature of this vitreous. You have that staining right over the macula, but then when you did get that off the nerve, you see there are actually like two planes. So beautiful video.
Hey,
Yeah,
Ferris,
so
go ahead.
sorry, I just wanted to hit back to Carolyn's point to that. So what does that mean to you? We have a lot of early in the year fellows and residents. What do you mean skidic? And is there a way that, should we be doing something different right now to figure that out?
Well, I think they stained, it's a lighter stain for that layer that's closer to the retina, but oftentimes surgeons will see just the staining of the highlight over the macula and they think, oh, it's just like an ERM or a little thing that's left. We have a PVD elsewhere. But you can clearly see when you see the white string that he lifts that there is the posterior highlight is still down everywhere, and you're just getting that pre-macular bursa that's stained with that more prominent staining. So you can get tricked or fooled.
Would you put more catalog in at this point, or are we good?
I probably would, teaching a first-year fellow, just because I know I can see it, but I don't know if they're seeing what I'm seeing. That's usually the challenge when you're teaching young surgeons. The only thing that made me nervous at the very beginning of this case is when you put down the catalog and you kind of left it there, and then you started to do the PVD right away. I like to actually get away from the retina first and then aspirate so the catalog kind of like mixes around just more diffusely. When you have it so close and now it's kind of swirling around, you lose sight of your port and your cutter tip. And as an attending, that's when my heart rate goes up.
Got it.
So Ferris, obviously this was your first case and you lifted the PVD perfectly on the first time. So great job. So tell us, what have you learned in the first 6 weeks or 8 weeks? What subtly differently do you do now than you did when you first tried this?
I think, try to spend as much, spend more time close to the nerve than you think, and try to, do kind of a rocking movement just to try to catch as much high-load as possible close to the nerve, and pull up. But, initially I wanted to do it as fast as possible just because I didn't want to kind of spend too much time close to the nerve. But if I think of it the opposite way, I think it's way more efficient to try to grab as much high load as possible, vitreous as possible, and then on full aspiration and pull up. So
I think as long as you have a pretty good view, I think doing exactly what you talked about, staying down longer and trying to really fill your port with the vitreous is a great idea. And I like what Kat said of maybe aiming your port towards the 12 or 6 and just going along that. And you did that a little bit here. You kind of walked along the arcades and trying to fill up your port. So I think you did a really nice job here with that.
So here I'm showing a replay, reverse and then back forward on full speed, because I think we can see nicely how the PVD is expanding into the equator approximately. You'll see in a second. Expanding here. Nice
video replay. Good job. He's already got his video skills down. He's a first-year fellow. Nice work.
Very nice.
Dr. Rachitskaya completed the PVD, extended it further.
What do you think she was doing that differently than what you were doing?
Breathing.
I felt like she yeah. I think she was going kind of into the whites and maybe going a bit more under under the posterior hyaloid face and kind of lifting a bit further. Obviously she's more comfortable doing that, so I think that was successful.
I think it's probably it's more of what Kat was saying in the beginning. She is getting more purchase of that hyaloid, whereas earlier surgeons again are scared, and so you don't vacuum enough, and then you start pulling, and you're just getting strands of hyaloid.
Yeah, I think
exactly.
really getting into that plane is really important. If you, especially if you can see where the Weiss ring is, or sometimes if they're between the premacular bursa and the nerve, there's a potential space in there, or an actual space. You can sometimes just dissect your way in there, or just cut your way in there. It's terrifying a little bit because it is in that papillomacular bundle, but if you can see it there and you can stain it there, you can just get your port in there, and then you have yourself in the plane, and that's when you can access and pull it up.
So here we complete the vitrectomy. This is a phakic eye. So I find in my hands, maybe at this stage, more natural to go from 6 to 12, or at least that's what I've tried a few times. And then we switch hands and complete the vitrectomy the other way. This is 8 times speed.
I like how honest you are about how sped up it is.
Yeah.
He wasn't going to let us give him a compliment. I like
Very
it.
detailed. It's not 6 times, it's 8 times.
8 times.
I think iVideo gives you like 1, 2, 1. It's like 1, 2, 4, 8 as the option. So got his rabbit on like high speed.
We stained with ICG again with reflex technique. Here, actually, I sped up that portion here, but I wasn't sure why I was getting so much kind of flow. That's kind of, you see here. I'm not sure why I was getting so much kind of DSS going into the eye. That's clearing that ICG more than I would have liked.
What do you think now? What do you think what happened?
I think maybe I was maybe kind of venting, or and then
sometimes
the IOP dropped. Then
yeah, sometimes there's a leak around your port. I mean, that's sometimes there's just there's a broken seal, or just a tiny leak, or sometimes you're aspirating more than you realize on that reflex technique. And so it can occur. Sometimes I clamp the infusion if that happens, but you have to remember to turn it back on. So you have to be very, very careful if you clamp, because you have this tendency to, when you take it all out, to just go right down onto really high mag.
Yeah.
Sorry, high vacuum, I apologize.
So here, pointing the light away from the macula inferiorly. And removing, sorry?
I think you're okay to go, Ferris. Yeah, sorry.
Yeah, removing the ICG. And one thing I learned here is kind of stay longer and vacuum longer than you think. Maybe I do like 5 to 10 seconds extra after kind of clearing the ICG.
So
Dr.
I'm gonna
yeah, go ahead.
Is Sumit with us? Dr. Sharma? Maybe not.
Not yet.
So not yet. He's hiding. So here's the question for Loshan. So fellows going into the eye for the first time with macular lens on an instrument. So what are you guiding them so that they don't like poke a hole in the back of the eye? And then I'm going to ask Ferris that same question now that he's done this. What kind of clues can you give us as to how to orient yourself? Loshan, can you take that?
Sure, yeah. The first time you go into the eye with such a limited view, it can be very terrifying because you don't know exactly, especially, where any of your instruments are. So go shallow, right? Obviously, you don't want to go too shallow, so you hit your lens, the patient's phakic, but enter slowly, shallow, and right toward the middle so that you can see, toward the center of the globe, right? So that you can see your light first, and then try to illuminate the tip of your instrument, and then you reorient yourself from there. And then, and then focus down on your macula, basically. But, the most terrifying thing is not being able to see the tips of your instruments.
Loshan, you used terrifying like 3 times in that sentence.
Ferris, are you
where I stand in
terrified
most
at this
cases.
point? And what did you
Not yet.
what did you take from this?
At this point, not yet, because I didn't know I was going to peel. So Dr. Rachitskaya is starting the peel for me with a finesse loop, and I still had no clue I was going to peel. We are using Ingenuity, but this video is taken from the Zeiss microscope. So this is on Ingenuity now. So I'm asked to peel. This is the first time I peel in a kind of pristine eye. In the past, maybe I had peeled kind of a PVR membrane, but it felt really different here because I'm thinking, you know, this is an eye that's kind of relative. It has a macular hole, but it has really, really good potential. And I was more anxious here than, you know, peeling, you know, a membrane, a PVR membrane, or a PVR membrane that I had done in the past, because the eye is just so pristine. So here I'm sitting and looking towards the right because we're using the Ingenuity, and I try a few times to catch that flap. Unsuccessful. This is real time.
I appreciate, Ferris, that you did not speed up here. I think
Yes.
that
This is
most of our
so
first year
great.
fellows would be doing the same stuff. Yeah.
This is a great video. Everything you're doing is what every fellow does. We're going to talk about each thing. Good job.
And I'd
But now
much
I
rather, as an attending, have you like grab a couple times and miss than grab too deep. Like you can do what you're doing and I can let you flail a little bit, but the minute you start sort of grabbing a little too deep, then, you know, you're quick to switch. So I think you're doing great.
So here I catch it, and to be honest, I don't think too much about where I should be going. I think I just pull towards my, you know, just parallel to where my instrument, and you'll see, you know, I don't, you know, propagate that very well. So not great, but now I'm thinking, you know, I've seen people doing pseudophakic. I used the light pipe to kind of clear that that ILM from the forceps, but I was told, you know, better not to do that in a phakic eye. So it gives me the chance to do instrument, and I try to shake my instrument, try to drop it, no success, and it gives me the chance to kind of reset my mind and adjust how I was sitting. So we're using the Ingenuity. So I like to use a chair with a backrest, but I think I was leaning a bit too much backwards, looking at the screen. So I readjust the way I was sitting. I come a bit forward, and just being closer to the eye, I think, gave me kind of better ergonomics to successfully peel in a second. So here we're doing instrument wipe. I'm adjusting how I'm sitting.
I think that's such a good point. You know, I used to always think before I started fellowship that most of peeling would just be actually those fine movements I'm doing inside the eye. But actually peeling is very mental. And sometimes, you know, you have to pay attention to just as much what's happening outside the eye as inside the eye. Make sure you're comfortable. Make sure your hand is well supported. I always have the wrist rest on. Some of our fellows will sometimes put towels on. But just really make sure that you're comfortable and well grounded, because if you're not, you know, any little tremor you have is just going to get a lot worse. And if you're not comfortable, then it's going to be really hard to peel.
So here I catch it, and I'm thinking, I am not letting go. And basically, I'm going to try to go down, because initially when I went parallel to my forceps, you know, I cut through it. So I'm going to try to do a sort of a rhexis movement. So I go across, and here I'm looking at my instrument. I'm not to be honest, I'm not looking at anything else. And then here I stop, because Dr. Rachitskaya says stop, and I think rightfully so, because there was some traction on the fovea. I don't think we see it very well, but we had a small tag of ILM stay in the fovea, or starting to kind of stay, and then I stop.
The other thing to consider is your flap is getting very long at that point. And so a reason to stop is also just to regrasp a little bit closer, because once your flap gets really long, a number of things can happen. You can just amputate it, which is not the end of the world, or you'll just end up, you won't get a good mechanical advantage because the angle is weird, or you'll end up pulling something that you're not trying to pull, which is what you were talking about.
I do like that you said you are watching the tip of your instrument, because, you know, the eye is like a bowl. And if you're watching just your flat matter instrument, I have had fellows touch down with the tip of their forceps as they're coming down like the lowest part and then coming on the other side of that bowl. So,
you know, Ferris, for this being your first alpha pill here, I mean, this is incredible. You're doing so well. You know, a couple of, you know, I think you're being safe, which is great. And I think we're all pointing out the little things that you should do, but this is fantastic.
A second, it looks really awesome. One question also for anybody, for also the group, if you do end up pulling your flap off or amputating it, which happens all the time, and you're not quite done with your peel, I've seen a lot of fellows do this. They'll like scrape that little piece off with their instruments inside the eye. And I was just wondering what people's feelings are on that. I was never that way. I would pull the thing out of the eye and like wipe it off with an instrument wipe and then reinsert. And I'm not sure where that came from, where you just like wipe it off inside the eye and, you know, go on. Maybe it's because you feel uncomfortable going back in and out of the eye like that.
Well, Shen, this is number 600 on my 700 things that annoy me. That's exactly right.
And I think Ferris made a really good point. There's something that can be gained by, especially when you're in the midst of something, things are shredding, they're stuck. You know, you come out and you clean it. Yes, so it's not like floating around in the eye. Sometimes it can get caught at the very end in your cannula and you think you're out, but it's stuck in the cannula. And the worst thing is like if there's a floating thing of ILM the next day, then you're not happy. But it also gives you a second to pull the instrument out, you're wiping it, you're kind of getting reset, refocused, and you come back in again. And I think that really, that does a lot for the attending, because then, you know, we know that there's a chance to kind of talk about some things. But even for the fellow, you can think about, okay, I pulled here, I amputated there, I need to try this side or that side or change instruments. So I think in some ways, yeah, it's a like a routine maneuver, clean up the tips, and I like that. But it's also a second to kind of like re-pause. The other thing that I've seen happen is like someone's flicking, you know, that instrument like with the light pipe and whatnot, and then there's an inadvertent hit. I mean, that's just over.
Yeah. I think, you know, limiting those movements that you don't need to do in the beginning. Those are like, to me, like when the second years do it, I'm like, okay, fine, you're showing off. When first years do it, I'm like, chill. You know, you don't know where your instruments are. And Ferris, I think you showed us something really nice. I just want to compliment you. You know, your mouth of your forceps was open pretty big. And I usually tell people to make it a little smaller, because your hands tend to go a little forward when you close the tip. So, you know, you did a great job of that. But, you know, one of the tips I give to my first years when they first start out is bring the tips a little closer before you get close to the membrane. But that was great, man. You did an awesome job. That's a fantastic first peel. Good work.
Thank you. Thanks.
Prithvi, what you got for us, buddy?
I got Jonathan Lin. Jonathan did his MD and his PhD at the Washington University at St. Louis, and did his residency at the Massachusetts Eye and Ear Infirmary. And he is going to tell us about a case that we did probably in the first month of fellowship. Jonathan.
Great. Thank you so much for the introduction. I'm really excited to be here and be able to share this and to hear all the tips from everyone. So this is a case that I did early on with Dr. Mruthyunjaya. And so here we go. So this is a case of a 52-year-old female who presented to the Stanford ED with decreased vision in the left eye after trauma. She was playing softball. And of course, the one time she wasn't wearing eye protection, someone pitched her the ball. When she wasn't paying attention, the ball hit her squarely over the left eye. Immediately noticed decreased vision. After that, so went to the ED. Had history of myopic LASIK in the kind of distant past, but otherwise no ocular history or medical history. On presentation to the ED, this is what we saw. Vision at this point was 2100, intraocular pressure was 15. You can see pretty clearly from the picture that there's a crystalline lens that's anteriorly dislocated into the anterior chamber. And it's hard to appreciate, but you can sort of see that inferiorly there's kind of the start of some corneal edema. We were able to take her to the clinic shortly thereafter and get some anterior segment OCT, and you can see very clearly this lens kind of very far into the anterior chamber, and there is some kind of degree of lens cornea touch inferiorly. Optos images, right eye was unremarkable. Left eye was sort of a hazy view, but no obvious detachments at this time. We also performed a B scan to confirm that there were no retinal detachments. So at this point, kind of the plan was to do a pars plana vitrectomy with a lensectomy. And given some of the kind of corneal changes, some of the edema, the thought was that this would likely be best done as a staged procedure because of the difficulty of obtaining accurate biometry at this point. And so the plan was to do a lensectomy, leave for a phakic, and then plan for a secondary IOL placement at a later date. And the plan was to do this within a couple of days, kind of on an urgent basis, not emergent. However, a few days later, she presented back with eye pressure, further decrease in vision. So at this point, she was counting fingers. Intraocular pressure was found to be 47. Fortunately, we were able to bring her pressure down with maximal medical therapy, but the urgency of the case was moved up quickly. And so this was done the following day. So I can show you the video now.
So, John, did you meet this patient before were you taking care of this patient in the ER and such, or this was someone that was signed up?
So I met this patient like a few days after they came. So they met the resident team in the ER, and then they were referred to the retina clinic for evaluation. I met the patient kind of at that stage.
So the reason I ask you is you look at the schedule and you see it's a lensectomy. How did you get prepared to do your first lensectomy? Like, what was like, so just take us through. You've never done it before, I'm assuming, but how'd you prep for it? Give us the tips.
Yeah, so I think I've seen lensectomies done, mostly posterior lensectomies, never ones in the anterior chamber. So I was a little bit unsure what exactly the plan was going to be. And so I, fortunately knew who I was doing this with, and so talked with Dr. Mruthyunjaya before the case to kind of go over some of the thought process here in terms of what we plan to do. And so our thought was that in this relatively young patient, obviously this lens is full in the AC. Trying to do a phaco, with a capsulorhexis just seemed that that's obviously not going to work. And so the thought was to try our best to remove the lens kind of in situ in the AC where it was, and then kind of deal with whatever moved to the back, and since the patient was on the young side, we thought likely we wouldn't need to, get like a frag, for example, and hope that we would be able to get all of it with the vitrector. But we were kind of prepared for that possibility if we needed to.
Yeah, the point I was just trying to make is like, most of the stuff in the first couple months is all new. I'm doing this for the first time, and it's okay to ask your attending. It's okay to ask your senior fellow. It's okay to ask, people who maybe have a little bit of information, so that when you walk in with Dr. Mruthyunjaya, you can say, oh, I know this, and I've seen this video, or I like saw my senior fellows. They shared some stuff with me, and I think I'll have a little more comfort, more prep before and especially with Prithvi, because he's a tyrant, is usually a good thing.
Yes,
very important.
All right. So this is just showing you the surgical view. It's hard to appreciate in the video here, but there's some corneal edema still inferiorly, not so bad. So our plan was here to use a 23 gauge vitrectomy to kind of increase kind of the efficiency of lens removal. So you can see I'm placing the infusion cannula. So here you can see I'm having some difficulty kind of visualizing the tip of the cannula. There's a bit of an inferior rhodophysis that you can sort of appreciate. And so it was very difficult to see it. Eventually, I decided that we would come back to that to verify the placement a little bit later. So continue with the placement of the cannulas here. So again, I'm kind of struggling to make sure I see this tip of the cannula. Eventually I do think I see a glint of metal, which we'll come back to a little bit later in the case. And so we decided it's okay to proceed. And so as we mentioned earlier, the thought was to do kind of with the anterior approach first. So we make 2 paracenteses and put in some Helon to protect the endothelium and try to kind of keep the lens in the anterior chamber. You can see here I'm going in with the Drysdale to kind of place behind the lens to hopefully keep it up in the AC. And fortunately, this lens is pretty soft, and so just with the vitrector, it actually comes pretty easily. You can see I'm kind of working my way slowly through, making sure to stay kind of within the meat of the lens so I don't inadvertently eat, other parts of the eye that I don't want to eat. And you can see here, I'm just refreshing the endothelium a little bit to kind of make sure we protect that clear cornea.
So Jonathan, was there any thought from coming from your ports to come, to try to stay away from the cornea?
Yes, there was. I think it was a bit of a balancing act because I wanted to simultaneously keep the lens from falling with this Drysdale, but also, not move so anterior to as to cause more corneal edema and decompensation. I think one thought we had was like, would it be possible to, this is kind of not at this stage, but earlier, like, would it be possible to just let the lens, fall posterior and deal with it kind of in the vitreous? But just given the size of the lens, we felt it would be probably difficult to just like prolapse it back into the vitreous.
What were your settings on your cutter during this point of the case?
I think we reduced the cut rate. Dr. J, is that correct? Yeah.
Yep.
I don't know the exact number, but it was much reduced.
Around 1,000.
Any thought of putting your infusion in one of the other ports, and then adjusting your paras? So like you felt to see maybe you'd be more confident in the infusion placement before you did. Yeah, you're all anterior, but you're still relying on the infusion port to inflate the eye during this part.
Yeah. The truth of the matter is, I felt at this point fairly confident that it was in the eye. We'll see shortly. I mean, unfortunately, there was no major, like, I think, if it had been like definitely not in the eye, we would have seen hopefully something that would have alerted us to that at this point. But I think the reason we didn't is because at this point, I really didn't think that it was in the correct location.
And as the attending, like, I asked him, can you see the infusion? And, we were struggling, and then we were pressing, and then he felt he could. And I think at that point, probably, then I said, great. But, there was some indication as we were doing this, maybe like the eye wasn't maintaining, we weren't keeping up with the infusion as well. And I think as the attending, I should have said, you know what, let's reconfigure this a little bit. Nothing was catastrophic, but something wasn't going just quite right. So it was always in the back of my mind. I just didn't act on it fast enough.
Like I saw you pushing on the infusion during some of that. I've just had a couple first-hand experiences where similar case, and then suddenly I'm seeing retina behind, and that's the worst feeling on the planet. And it wasn't like a choroidal retina, but a rhegmatogenous retina. So these are things that now I will never forget. And so anytime the infusion doesn't seem quite right, I'm kind of super paranoid about it.
And then we came from the front because if we were able to get it all out and then do an anterior vit through the cornea, even though we put the ports in, we didn't need to go into the back. Our goal wasn't to induce a vitrectomy, but we didn't have a clear view in the clinic. Some of that was the cornea, some of that was the lens, but we were prepared to do so. But if everything came out perfect and we cleaned up the AC, we could have just, sutured up and gotten out of there. So it wasn't a must that we had to go into the back.
Was there
a
cap, Prithvi?
We did. What's that?
Did you have a discussion of intracap? So like dilating the capsule, making sure there's no vitreous in the AC, and then just birthing that baby out.
Yeah, what fun is that? No, actually, we talked. We probably talked very briefly about that. I think our goal was because we, she had trauma. We weren't sure what was going on in the back. We couldn't get a clear view. I think our goal was anticipating to be going into the back, but that would have been a great idea.
So, Prithvi, can I push you on this a little bit? I mean, you have a trauma patient, a blunt trauma patient, who's a myope, now with a dislocated lens with probably vitreous prolapse. So you don't think you would have done a vitrectomy? I mean, it seems like this is a high risk eye.
Yeah,
right. Even in this scenario where you cleared everything out, right? I think you're doing the vitrectomy regardless, right?
Our plan was that, but I'm just throwing it out that, like, if we got the lens completely out and we were able to clear the anterior vitreous, if anything was prolapsing, we could have been as minimalist as stick a light pipe in and and scleral depressed, see what we find, and if everything looks good, then don't get into a messy situation. But I was anticipating that we were going to need to do something. That's why we put the ports in.
Gotcha.
I wasn't keen on just trying to just address the lens. I think there was going to be more than that.
Sorry, Jonathan, go ahead.
Keep going. Yep.
So continue to slowly get this out. This is sped up yep. And so there you can see we did lose a few pieces. So unfortunately, we weren't able to finish this so quickly as Dr. Mruthyunjaya had hoped. So you can see here, we're doing a little bit of anterior vitrectomy, making sure that trying to clean up any residual vitreous that may have prolapsed, cleaning by the wounds. And at this point, we felt that we were done at the front and we wanted to look in the back. And so we hydrate the wounds and start to take our first look at the back. First thing we wanted to do is to make sure that infusion cannula was in the correct location. So we wanted to visualize it. So you can see we're kind of pushing, and it's not really clear exactly. We see kind of the glint of the metal there, but it doesn't look like definitively in the vitreous cavity. And so we decided at this point that we will move the infusion into a different location, and that way we can use the light pipe to go in and kind of get a better view of where this cannula is exactly. Of course, we want to make sure that this one is in the right place, which it is. And so you can see now we're going in with the light pipe.
Oh, there you go.
Yeah, so there's I kind of froze it there, but you can see it's not like subretinal per se, but it's definitely not. It's like kind of on the very edge of disaster. And so at this point, we do use kind of the trocar again, try to really push it to see if we can get it, fully through. But eventually, we decide that we should, close this off and then go elsewhere. And so we suture the sclerotomy, and then we decide to move the infusion infranasal instead.
Loshan, anything else we could have tried there, or you would have tried at that moment? You have a little bit of pars plana epithelium covering your cannula. There's no detachment. You're not subretinal. Do we have to move the port?
I mean, that would be my preferred. I mean, I don't see any reason, but say like there's a tube in the other quadrant or something, right? And so you don't have the other quadrant to work with. Then you could go in with an MVR. You've already made incisions. You can go in and try to like just incise it. But I'm always in favor of just moving it somewhere else if you can.
Go ahead, Jonathan.
So we move it. We want to confirm again the positions with light pipe. Clearly, this is in the correct location now. So we move the infusion to that location.
So Jonathan, when you saw that when your light pipe pushed in, were you the one who said that you saw the tip originally in the right place?
I was, yes. So
tell me what you're feeling. What you like take away from this? I mean, look, this happens to all of us. It's not to put you on the spot, but the purpose of this is education. We all go through this. What do you think? In that you missed, or what fooled you? You think?
Yeah. I mean, so the eye itself has some kind of weird optics because of the dial. So I think the kind of hint that I should have paid more attention to was all the difficulty we had. I think most of the time when we do this step, it's pretty obvious what we're seeing, and we kind of move forward. And I think I felt, like there's a little bit of a pressure. You're trying to see this cannula, and you kind of feel like you're you're not able to see it. It's like you're doing something wrong. And so I think seeing or noticing that it didn't look quite like I expected it to look, I definitely saw a glint. I'm pretty sure I saw a glint of metal, but that, like I think knowing that isn't sufficient, and kind of really making sure that I see like the cannula fully into the vitreous cavity would be.
Jonathan did report me to HR right afterwards for bullying him to prove that the cannula was he could see it, and I think and that's probably not to be understated. Like you just assume it's going to be there, and most times it's there. But it also goes to the point that we always check, right? That's never a step to take for granted in whatever case you're doing. The easiest whatever pucker, peel, like, you still can't, miss those steps. And this was one where, we probably should have, it wasn't so clear. It wasn't essential because for the first part of the case that we had to be in that port. We were going to go anterior to go after the lens. We could have moved it immediately and then come back. 6mm infusion, 6mm cannula, I think was a great idea. We had many options at that moment, but it was just confluence of a lot of things that made that hard.
Yeah,
but he still did it for me.
I was gonna say the fellows also know that I make them look at the infusion port placement after the infusion is on. Like I say, like, do you see it? And then they always like, yeah. And then I turn it on and they look away. I'm like, no, go back and look again. Because especially if you put all 3 ports in, the eye's a little bit hypotenuse. You turn the infusion on, the eye inflates, and that placement will shift. So that is also another part where you thought you saw it, but then maybe when the infusion went on, it might have just shifted a little bit and be more shallow than you originally thought.
Yeah, these are just all great lessons. I mean, it's the first critical step. And this will happen to everybody here. Everybody who's a retina surgeon, who's ever done a case, you will get this and you'll miss it. And it's important. And I think you, Jonathan, are showing this. It's really, really important. And I think we all can take something away.
Yeah. And as the attending, you can often, you ask them the question and you get a sense for how sure they actually are. Like, you see it? Yeah. Are you sure you see it? Yeah.
It's hard because the fellows want to see it, right? You're like, I see something, but you have to learn to be like definitive about it. Yeah.
Don't be bullied by your attending. This is the only lesson.
Especially your program director. Yeah, absolutely.
Right.
The Stanford program director. This doesn't happen.
Yeah, sure.
Keep going, man.
All right, great. So now that we have all our reports in the right place, so we're just doing corticotrectomy here, kind of working across. Fortunately, this eye is aphakic, so no risk of hitting the lens here. So with these lens pieces, the goal was to kind of use the aspiration with the cutter off to kind of pull it up away from the danger area, and then if needed to use the cutter to kind of to eat the pieces. I actually found that kind of fortunately the pieces were quite soft, and so they actually mostly came in with aspiration alone. So we're just kind of now using Kenalog to stain for kind of residual vitreous. And you can see that there are some, it wasn't clear preoperatively. The OCT, the view wasn't good enough to really know whether the PUD was present, but there do appear to be, some possible hyaloid attachments down below. So you can see here I am gingerly trying to aspirate, kind of pull these pieces, this hyaloid off of the back of the eye with some difficulty. And so here's where Dr. Muthanjaya steps in and helps me out a little bit in a few moments. All right, so switch seats. So he uses the flex loop instead. I think he did try to use aspiration initially. Did also had a little bit of, it was kind of stickier than expected, and so was able to kind of remove some of these with the flex loop.
Do you have to?
You're living. Yeah, exactly. What are you doing, bro?
I was like, I'm learning something. This is such an amazing technique. And then I was like, what is Christy doing?
What are you doing, man?
What were the phobia?
Yeah. Oh my God.
Giving me palpitation.
Oh, not like my first case. It's just don't do what Prithvi would do.
Oh my God. This is completely incorrect. Do not do that ever. If you do that, I will throw you out of the fellowship immediately.
Oh my God.
Oh God.
So then we just proceed with 360 scleral depression, shaving to look for
the hyaloid came up, everybody, just for the record. It came up.
Yeah, because you scraped the fovea off. That's why.
X-ray vision.
The intraoperative OCT shows no foveal dip, but a couple of wax into the fovea. Go ahead. Sorry, man.
It's all good. So we were kind of tuned in and really wanted to make sure there were no breaks in the peripheries, given the trauma and the history of myopia. Fortunately, we only found kind of 2 areas of what appeared to be intraretinal hemorrhage, inferiorly and kind of infranasally. No clear definitive break, but we decided to laser them out of an abundance of caution. So we did that. Unfortunately, we looked pretty carefully also in that inferotemporal area where the difficulty with the cannula didn't see any concerning there. And then we sutured up the sclerotomies and then finished the case. The patient
Jonathan, I feel bad because we spent most of this case just ripping on Prithvi. But as a learning point, maybe to share with other fellows or prospective fellows on the call, when you were picking up those pieces in the retina and they're like bouncing around, did you adjust your settings at all? Did you like change to vacuum only, cut her off, and then cut? Like, what were you doing with your hands and your feet and your settings? Can you share?
You're talking about the anterior portion or the posterior, or both?
No, the posterior portion. Like the anterior portion, we talked about that. But in the back, you had these pieces, and if you just like sit there with your cutter, they're going to fly around, and you'll get lucky, and a lot will fly in. But you also have pieces bouncing all over. So, what was Prithvi telling you?
Or
what were you ignoring Prithvi and doing because you have surgical intuition?
Yeah, so I think for those I was kind of would go in, cut her off to get the kind of the cutter port close to the lens pieces. And then I would kind of slowly engage to try to pull the kind of get, as you would do with like cataract surgery, kind of get occlusion and then kind of pull the piece into the mid vitreous in a safer zone. And then the plan would be to kind of then kick over to the right, turn on the cutter, and then eat the pieces. So I think that would kind of help minimize the kind of random flying around of the piece. I did find that these pieces, because the patient was relatively young, they actually were pretty soft. And so a lot of times, even without the cutter on, the pieces would start kind of folding into the vitrector with sufficient aspiration. But I think here I was trying to pay attention to make sure that I was a good ways away from the retina before allowing the aspiration to be at full speed to avoid giving my faculty mentor a heart attack in the chair next to me.
That's fair.
I mean, if the pieces were harder, if it was a lot bigger, some people will put a bubble of perfluorine in the eye just to sit on top of the macula. I don't do that myself, but some people will advocate for doing that just to prevent the pieces from bouncing off the fovea.
Yeah, I think we actually talked about that preoperatively. I asked Dr. Muthendra if we would do that. I think he told me, and if I'm sorry if I quote you wrong, but I think he said that sometimes that helps, but sometimes the pieces also just kind of fall off to the side of the bubble, and then you're kind of in the same situation. I mean, I guess away from the fovea, but still near the retina.
And then I think in the chat they talked about it, but I would just make sure you do a really good depression, because you can find little chips that'll get stuck in the vitreous space or the anteriorly. And then the worst thing is post-op, seeing it flying around or floating in the bottom of your retina or your vitreous cavity.
So the patient is doing, I think at this point, she's about post-op week 3 or 4. Has been doing, was doing well at post-op day 1 and week 1. Vision's about 2100 with pinhole. Obviously would be better with aphakic something, but she's doing well, and the plan is to let her heal for the next probably month or 2, and then consider secondary IOL at that point.
Awesome.
Very nice.
What a great job. Good work. Despite your attending, you did fantastic work. All right.
Next.
So next up, we have Joe Abraham. Joe did his medical school here at Case Western at the Lerner College of Medicine, and was our resident here at Cleveland Clinic, and now is our fellow. Joe's going to show us a retinal detachment case. Is that right, Joe?
Yep, that is.
All right, take it away, man. And I'm sure your attending was much better. So you'll do
No, this is my case, and I have to say, I think I'm more nervous right now than Joe is, because you guys are all rough, and you're gonna like rip me apart. So this
yeah, Prithvi's now like going to be primed. He's going to take revenge right away.
I know.
I'm taking it out on your cat.
No.
So now I'm nervous because I thought this case went relatively well.
I'm sure you're doing great, man.
All right, so we had this 66-year-old male presented with left eye floaters that have been present for about 10 days, but 3 days prior to presentation, he noticed a veil over his vision and had been steadily decreasing. No trauma. Time this a little. Okay. Nothing really super significant on the in terms of the surgery here, but has several systemic comorbidities. Base exam, he was 20/60 with pinhole, pseudophakic, PVD was noted. And so we have a picture of his detachment here that does involve the fovea there. just barely. So now we're going to start. Okay, so we're just putting our trocars in.
Wait, so what was the plan? Yes, you're doing a vitrectomy, but just was the plan to do just a primary vitrectomy?
Yes, plan was to do a primary vitrectomy. The breaks were superior, and there was just one break identified on depression prior to operating.
And choice of gauge is just surgeon's choice, or?
It's my choice. I love
yeah.
23 gauge for RDs. I just find it so much more efficient. But I'm in good company, I think, at Cole with some of our older surgeons. I think I'm the only young person who's 23, but I like it.
Hey, Dr. Sharma, I have a question.
It's like me and Peter.
Sumit?
Yeah.
Sumit, I was any guidance as to where this cannula needs to be placed when you have a superior, say, supratemporal detachment?
It's a great question, right? So you want to worry about where you put your instruments, especially when you want to be able to access right underneath it if all of your pathology is right there. So sometimes if you know pre-op where the pathology is, you may shift some of your cannulas over and go either a little lower, or I don't really like to go more superior because I find my hands getting kind of cramped, but I might go a little lower just so I have easier access to it.
I think in this case, he has a little bit more forgiveness because it's a pseudophakic patient, but with a phakic patient, I agree with you 100%.
Now we're getting into the eye and we're doing a little bit of core here.
Yeah, I think there's a mic that's on.
Okay.
If you wouldn't mind, not yours, Joe, but somebody else, if you wouldn't mind muting yourself. We want to hear you. Go ahead.
So over here now, I'm just taking about to just take some of the traction off near the break.
Julio Zand, could you mute yourself, please?
All right, I think
go ahead,
we're good. So at this point, I'm still relatively early on in doing detachment repairs, and it's the instinct about taking the flap with the cutter is I still have to like defy my judgment to still do that. I still get pretty nervous about taking the retina there, but
have you changed your settings yet?
What was that?
Have you changed your settings yet? Like what settings are you on at the moment?
This was a lot of modulation was happening. Like I was being pretty mindful of the bolus component there. I wasn't going too heavy on the pedal there.
So I think Loshan's question was, were you on like your core setting with like, were you like 10,000 cut rate and like 600 vacuum, or were you like on shave mode where your vacuum level was lower? What were you on, do you think, at this point?
There's how to correct me if I'm wrong, but I thought that we were still on core, but I was vacuuming a lot less than 600.
Yeah, we were on core here. I think one of the problems that I thought would make this case a little bit harder at the beginning for Joe is the retina was just really bolus. And so I thought since the tear presented itself, we would go with the flap, and that might help to defervesce some of the bolus nature of the RD, so make it a little bit easier. But I was really depressing in, and he was just gently pressing on the pedal. But we could have shaved here. I just thought if we got the break, it would make it a little bit easier for Joe because the retina wouldn't be flopping around so much.
So eventually we do manage to get that flap there. Some of it is still there, but we get it eventually. So then we're putting in some Kenalog for staining. We had seen the PVD and on exam and on imaging to be confident of that here. And so now we're doing a peripheral shave around. I'm still working on maintaining the cutter in the right plane as I'm moving across, because I do, I feel like even with and maintaining the lighting too, so that I can see clearly where the vitreous is as I'm trying to go around 360. I do find that I still have
Hey,
the
hey
tendency.
Joe, teach us something here. So now that you've done this, a couple of times, more times, what have you learned from light positioning from this case and now your subsequent
Yes.
cases? Like where are you? Where is that light pointing for you? Give us some tips.
I'm a lot more mindful now of how far in my light pipe is in the eye, because that really affects how broad your illumination is. And depending where I'm trying to peripherally shave, redirecting my light so that you can see the vitreous more clearly is something I'm slowly getting better at. But yes, the lighting was definitely a learning point for me going back on this, because I was like, wow, I am suboptimal in my lighting here, a fairly high percentage of the time.
I think you're doing great, Joe. I mean, to be honest, I think retina surgery is challenging, but it's not horribly difficult. I think the hardest thing about and the biggest thing about first year fellowship is actually just getting a good view and keeping a good view. Like if you have good visualization, you can do the rest of the stuff. But it's really hard at the beginning trying to figure out how to, get that good view and keep it even as you're moving around.
Yeah, and Joe, if you look right here, like your view now is great, right? If you look when you were shaving, just that your light was a little bit too close to your, your cutter, and you were just shining that you're shining the cutter really well, the shaft of the cutter, so you're getting all that reflection, and so that just takes time. You'll get that, but sometimes you have to pull back a little bit, and it's a very, very, delicate maneuver, and there's a lot of foot movement with your microscope as well, which takes some time.
Yes,
And
definitely.
the camera is much less forgiving than the microscope. So when you look in the microscope, you don't see nearly as much, but the camera, anytime there's a bright reflection, everything else gets dark on the video. So don't be as hard on yourself as you are being. Let us be hard on you. So
are you okay, Sumit? Because you're harder than the camera on the fellow. So,
I am. That's why I said let us be hard on you. Don't be as hard on yourself.
I think to Kat's point also, a lot of times the fellow doesn't even realize that the view is getting bad. That's the problem, right? So you're like, the view gets bad and they're like, I don't understand why this is getting so hard. And the reason is that the view is getting bad and they don't realize that the view is getting bad sometimes.
Yeah, it's amazing how the hyper focus can sometimes work against you.
So
Yeah,
can I ask
the
ask
most common phrases I say to the fellows is after the infusion is in is usually, where's my circle? Because sometimes they're like torquing the eye and I want a nice circular view of the retina. And then the second one is light better. And that's from the words that haunt me when I was a fellow from Hubschman was light better, light better, light better. So if you can like kind of remember that throughout the case, even now, sometimes I will be like, oh, light better when I'm doing the case as a primary surgeon. So it's something that you have to just practice and learn.
Prithvi, what do you tell fellows when they get caught in this? Like, how to, actually all the faculty, like a tip to get the lighting better, or what's your like take home message, or what's your number one thing you say first?
After I stop swearing, a lot of it is there sometimes is too far in and too close with their instruments, and it's just sometimes just stopping, getting that view together, and then just kind of showing as you pull the light out, you get a more diffuse view. So sometimes it's just like saying, well, this is what you're doing, and just look at what happens when you change, and then let's go for it. So kind of pointing where it should be kind of leading your cutter, but sometimes it's just kind of pulling the light back more anterior. So usually the words I'm using are, light more anterior, which is just to kind of give them the clue that they can get a more diffuse light. So yeah, sometimes just showing like what it looks like when it's good, and then let them.
So Joe, I'm sure that Dr. Talcott's talking to you during this case about how to improve your view. Tell us what the difficulty, if you will, of hearing it and actually doing it.
Definitely, I can't say that I'm haunted by it yet, but light better was definitely said several times during this case. And so it was just that, you're trying to be mindful of a lot of things during this, and to be able to more naturally just pay attention to those basic things that let you do everything else, like what Dr. Talcott said. Kind of once I'm hoping that, I'm sure it will become more natural to maintain the right positioning, because, you'll get just slightly distracted by what you're doing in the moment, and then the light pipe might be coming out of the eye a little bit, and then your lighting is obviously ruined.
Yeah, some of it's slowing down, I think, and just like hearing it and then just taking your time. So I just, again, the point is here, this is challenging for everybody in the beginning. And even as attendings, we still have to remind ourselves. Keep going, man.
All right, so now we're about to diathermize, I believe. I think I try to go from the proximal side initially and realize that was not a good strategy.
So this gets back to Prithvi's point about trocar placement, right? Just thinking about where's your break and try not to go right on top of it.
That is actually a great point. And so we're just shaving a little bit. I think Dr. Talcott, I can't remember when she definitely did some more peripheral shaving.
The teamwork.
Yeah.
It's hard because so much of the good, like getting a good peripheral view, is counterintuitive to what you think, right? If you want to see better further out, you actually need to move your scope in the other direction, which is just not intuitive for people learning retina surgery. So, some of it you just have to play with it, and then at some point it'll click over during fellowship, and it'll be like muscle memory. You won't even be thinking about it. I'm always aware of that. As the fellows switch over at the beginning of fellowship, I was like, because you just don't think about how you get a good view. And then as you're sort of teaching first years, you're like, oh, right, we have to go back to, because it's not always intuitive.
The other thing I find that,
go ahead, Sumit, sorry.
So I was gonna say, the other thing I find at the beginning of the year is there's a tendency to have your instruments horizontal because you're used to cataract surgery, and you really have to get used to diving down and keeping everything nice and vertical. And that takes a good month or so to get used to, and to really break that feeling. And sometimes it comes down to how you hold your instruments too. There's a tendency to just kind of flatten out your hands, and in a phakic eye, that can be really dangerous.
Joe, you're putting perfluorocarbon in now. Was that something that you had planned to do? And why do it now after the shaving is done and not before?
So that's actually a great point that Dr. Talcott and I actually discussed today, in terms of if we had put it down before, it would have stabilized the retina in terms of how bullous it is, and potentially made that peripheral shave a little bit safer for the early first year fellow. But yes, no, that's definitely something we considered afterwards in terms of looking back at the case.
And
yeah, I think that's a really good. Yeah.
Oh, sorry. You can answer both. So the question to you was perfluorocarbon something that I think you use more routinely with the early fellow in the seat? Did you prefer to have perfluorocarbon in versus just trying to do a primary drain without perfluorocarbon in this non-macula involving detachment?
Yeah, I generally actually don't use PFO, probably as some of my other colleagues at Cole. I love drainage retinotomies. I think they're fun to do. I think I do them more often than my colleagues. I think this also would have been a great case to just drain from the break. But sometimes I think that doing the endodrain is actually among the most difficult steps of doing retinal detachment surgery. And I think putting in PFO can make it easier at the beginning of fellowship, because you can laser under the PFO, and that makes it a little bit easier. When Joe sent this video to me and I was looking at it, if we had made the decision to use PFO, which I think we decided sort of mid-case, I wish that we would have put it in earlier, because I think it would have made his life a lot easier when we were doing the during doing the shave.
And another thing Dr. Talcott showed me in this, as I'm putting the PFO in and trying to squeegee all out that fluid out, was, and we're doing it here, as you're filling it out, torquing the eye in the direction so that the fluid is able to egress from the break more effectively. And so now we're about to start doing a bunch of laser. I might accelerate past this to another good teaching point for starting out people. Okay, I think it's about to come, maybe. And I'll be replaying it with smaller speed, but so there's a replay of the incident that's about to happen, actually. I'm sure somebody can guess
Like,
this.
you're making us just wince
Dun,
and
I know,
dun,
I
dun, dun,
know.
dun, dun.
All right, I slowed it down apparently, so I think I'm getting close. Yeah, here we go. There. And so I went a little too close with the endo laser. And you can see it again here that I caused an iatrogenic break there, right there, next to our other tear. So we just did some additional laser
I would
around.
say you identified a previously unseen defect in the retina. Good job.
So as you're going,
sequential breaks.
I would
As
not dictate, just
The
for,
no-
as to be serious, like I would not
dictation
dictate
is-
I created a tear. Like you just took care of it.
Yeah, it's just
All retina breaks for
another
laser.
retina break was observed. Anterior to the
Miraculously.
original break.
So as you're going to air, because we just want to keep moving, Joe, and just walk us through what do you think how do you think it happened? What do you now in hindsight? What do you think occurred? Just keep playing the video if you don't mind.
Oh, sure. So I definitely just got I was trying to get in around the tear 360, and positioning wise, I don't think I was using my right hand there most optimally to get to the break, and so I ended up putting it a little bit closer than I intended, and obviously caused that tear there. So now we're just doing we're under air here, finishing up the laser there, and we're about to finish up the rest of the case here. So yeah, no, it was a lot of fun operating with Dr. Talcott this day, and we did some BSS here just to make sure we got all the PFO out with the soft tip.
Can you just explain that BSS move for everybody?
So after, we obviously put a lot of PFO in, and so just to be cautious to make sure we got everything, we put the BSS in after putting the air in, just to make sure that if there's anything else posterior there, we're able to take all of it up.
Nice job, Joe.
Thank you.
Well done. Yeah.
Yeah, a lot of great teaching points on this one for all of us. I mean, I think you showed us some really good things, and really, this is, we do so many detachments, right? As part of your fellowship, I think really important to kind of take away these little points for all those who are watching or early on. I mean, these are things will come up, and I think are good take-home points. Prithvi, what's happening at AAO? What are you excited about?
Well, at AAO, everybody, we have.
Do you see your fellow just like shared screen and took away your your ump here? My God. Bertan, what are you doing, man? You haven't you're like 2 months into fellowship.
He's chomping at the bit. This is so at AAO we have a tradition to have COBRA live, and we call it COBRA After Dark. So it's going to be on Friday, October 18th. This is after the first day of Retina Sub Day, at 7:30 p.m. It's going to be at the Tao nightclub in Chicago. We had to choose this because Sunil plans to DJ his selection of 80s favorite dance tunes. But
I'm going to dress up with my 80s outfit. That'll be right.
Before he does that, we're going to have 4 great cases, lots of food, some beverage, and hopefully a good time to hang out with a bunch of young learners in the retina space and me and Sunil. So it should be a lot of fun.
And please, everyone come. It's free. Just sign up, and it's meant to be educational. Our second-year fellows are excited to show their best cases.
Right, and thanks again to Bausch & Lomb for supporting this entire endeavor. And now,
so Prithvi, who do we have left?
Well, the most eager fellow of them all, Bertan Katcher, is going to be joining us. Bertan's our first-year retina fellow. He did his MD and his PhD at the University of Freiburg in Germany, and did his residency at the Mass Eye and Ear Infirmary. And he is one of our awesome first-year fellows, showing us a great case. Bertan, take it away, buddy.
All right, thank you very much. Sorry for being so eager. I've been told I have only 15 minutes for this.
You got plenty of time. You got to take as much time as you need.
All right, do you guys see the primary screen here? Okay, so title of this presentation is Remember to Breathe. I think it's a common theme here. And it's a case of my first membrane peel with the case I did with Dr. Liang. So I'm going to go through this very quickly. So 71-year-old female initially presented just for a pre-diabetes check, and he had a history of retinal tears in the same year she presented. We didn't really find anything wrong with her retina. She was found to have predominantly visually significant cataract, which she was referred for initially, which was, at the time we got an OCT, which showed, a normal OCT with nice focal depressions. And then she came back 5 years later with, after she had the cataract surgery, now reporting worsening vision and new distortions over the past year, getting worse in the left eye. And what we found is that she had, significant thickening of the retina and epiretinal membrane. And so we discussed with the patient the option of a prospective vitrectomy with membrane peel and possible endolaser in the left eye. And she elected to proceed. So jumping right into my video. So we're beginning here with the core vitrectomy. Try my best to visualize the vitreous with my light pipe.
Britton, so as you're starting out, what are some of the things that you're thinking about when you're doing a core vitrectomy in a patient that's having a membrane peel? What are some things to know pre-op, and what are you thinking about as you first get in the eye?
Well, I want to know, if is the patient phakic, is the patient pseudophakic? I want to know what is the PVD status. The highlight is lifted. Ideally, that would be good to know. That's the main thing that I think about. And then we put on triamcinolone to see we got most of the vitreous and see if she has a PVD, which we felt she had. Then we proceeded with ICG, as the same case with Dr. Byers, and we placed.
So, Bertrand, let's pause a second. So, a couple of things. What were you seeing when you first put down the catalog? Was the purpose just to see if there was a PVD present or absent? And what are you seeing here with this highlight and staining pattern?
Yes, we wanted to know whether she has, if she has a PVD present or not. But also, I think what we see here, that's, some of the triamcinolone is highlighting probably the ERM essentially. That's what I think that's what's showing. Oh God. Sorry. So then I'm sorry that I missed that.
It's okay. It's good.
You're doing great. So and then you're using now the flex loop, and
Okay.
tell us like what were you like aiming to do? Were you going after the green stain or the white stain or both?
Yeah, so we were aiming to going for the green stain, so to catch the ILM together, ideally with the ERM later. And I predominantly chose a location where I felt like there was good accessibility, which was more infratemporal, and to create the initial flap, which I try to grab here. I think at this point I was not breathing much. It's quite nervous too.
So do the attendings oftentimes peel ILM with their ERM peels now to help prevent recurrence?
I always try and get the ILM as well.
I used to always peel the ILM, and then more recently I've done it less often. I would say probably about 70% of the time. For no
Just
real
pause
reason.
there, Bertrand.
Are there
So
breakout signs that make you decide to peel it or not, Roshan, or doesn't?
Yeah, I mean, so for regular ERM, if it looks particularly nasty, if there's a lamellar hole, then those are situations where I will lean toward peeling the ILM. If it appears more just like a VMT/hyaloid with a little ERM, I will probably not peel the ILM in this situation.
Sorry, Prithvi, interrupted you.
No, not at all. So, Bertrand, as you're coming through here, you are, you're using the forceps now. What are you thinking about in terms of which direction to be pulling? Talk us through what you're thinking.
Yeah, so I think at that point I was not thinking a lot about where I wanted to grab and where I don't want to pull. I was predominantly paying attention to how deep I am. I was trying to not to go too deep and able to grab the flap. And what was happening when I was trying to pull the membrane, that it kept on shredding for me, and I continued to grab into the center of the flap, and it kept on shredding for me as I was going. And in hindsight, I probably should have think about more where to grab and how the vector forces are, maybe more on the edge of the flap. So maybe that will, in the future, this will make it easier to.
Yeah. Keep going. Show us what you're doing. Oops, too far.
Sorry.
For those who always peel ELM with their ERM, do you peel them together, or do you do ERM first, then stain with ICG, and then peel the ILM second?
Bertrand, actually, could you just go back? Sorry, never mind. There is, I think, usually, Carolyn, to answer your question, I usually try to peel them up together, but a lot of fellows recently in the last couple of years have gone back to restain with ICG after the initial peel, which I have no objection to, especially if I feel like we haven't gotten the greatest visualization to begin with the first time around. I like to restain, and I personally have never had an issue with ICG toxicity, so I feel like it's okay to do. And I don't like brilliant blue in general.
Carolyn, I'll stain I'll stain again if it's a predominant ERM situation, because it's very possible you get the ERM off, you think you have ILM underneath it, and you'll still see a nicely wrinkled but still persistent ILM in some cases. So if I feel like there's a lot of traction and I really needed all the traction off, then another stain can sometimes help. And I tend to use blue these days rather than green.
Has anyone on the group seen ICG toxicity?
I have as a fellow, but not as an
years ago. You have to remember, it's just different light sources, 20 gauge, much different times, and much different concentration. So yes.
And Carolyn, what did yours look like when you had it?
It was just widespread outer retinal atrophy on the OCT, and then on autofluorescence as well.
Yeah, I've got one just like that, but one case very, very odd years ago, and haven't seen it since.
Yeah, this was 13 years ago that I saw it. I'm old school in how I was taught, and so we used to stain with just triamcinolone, peel the ERM with just the triamcinolone, and then stain with ICG. So it's only like one single stain with green, and then peel the ILM. But then the fellows come and they, want to do the combo, and I let them. I do think it's challenging peeling both at the same time, because the ILM is like more friable and shreds easier, and then the ERM is usually gummier. And so it's harder to predict those forces when you're peeling. So I do think the fellows sometimes make their life a little bit harder when they try to peel both at the same time. And sometimes when you just peel the ERM, the ILM comes with it, and then you stain for the first time after, and you are surprised.
Yeah, definitely. And then when you restain, you'll see like a big rip in the ILM, and you're like, oh, that's great.
Easy. Exactly.
Yeah.
And I think that's what we're seeing here. It's, I think the Bertrand, what you're going through right now is that the ERM and ILM aren't coming up together very well. So if you were going to try to do this, you might have moved a little more inferior and gotten all that ILM off, and then got a bigger flap of ILM to take the ERM. But when you're trying to do it this way, it's challenging, and you're wondering if it's you. It's not you. It's just the anatomy that you're battling right now. Let's see how you do.
And I think at this point, I grabbed a little bit too deep, and we saw a little bit of retinal whitening, and that's why Dr. Leong told me to stop, and I let go. But yeah, that was right before that. And there was finally got a little bit more substance here, but again, start shredding on me.
Yeah, so when you see that shredding, you really want to let go. and just go back and grasp again at the area where it's shredding. And I think often you can then continue to expand it out rather than it shredding. But you're doing great.
I think the single greatest superpower of a fellow is stopping when told to stop, right? Not to keep going, not to like pull one last thing, but when you say stop, just stop. And then there's probably a good reason you're being told to do that. Bertan's doing it really, really well.
Yeah, and then you get also there's when I was a fellow, I was watching my attendings really carefully, and you grasp, and then sometimes you just don't start pulling right away. You just do a little test pull, right? Just to see how it behaves, and that's how you know when you're too deep. And so you do that little test pull, and then you won't give anybody a heart attack. And then when you know it's behaving, then you can start actually peeling.
Yeah, the tendency when you start is to go down, grab, and move really, really quickly to get away from it because you're worried about being too deep, but it's actually the opposite of what you want to do. You want to kind of go down, stop for a second, and then go and do your grab, and really stop for a second and kind of go just slightly side to side to see what you actually have, and then you can pull.
Keep going, Bertan.
And
this view is interesting.
Yes, so I wasn't aware at the time. I think I was predominantly looking with my left eye, and it was a pretty tight orbit. And then when I watched the video, I realized that I probably was operating in a monocular state here. So that was a little terrifying to see. And then it's so I'm not exactly sure what there happened, but I was able to grab the membrane. And there's a little bit of a bleed, so I'm not sure if we had a small touchdown there. And now my view gets a little better after readjusting. There,
I think that's a very important point, and you're definitely not the first person to have had that happen, but it's very easy when you're focusing on so many things, especially in the macula, where so many other things could happen that either you lose accommodation or you go monocular for whatever reason. And again, a good time to just kind of refocus and recenter yourself, literally. But I think it can make a big difference. But this is going great. The ERM's pretty strong on top of this. The highlight with the triamcinolone really shows that this is a pretty involved ERM. So the ILM's not going to come very easily.
Unfortunately, this again shredded on me here, there, which is a common theme throughout this case. And then we tried to change our strategy a little bit. So I went a little bit more temporally next to initiate a more broader flap and then ideally come around. And it's lifting there. And then I try to go more superior to the flap. But for some reason, again, it starts to shred on me.
But I like how you keep going. You're following that line of force to try to get a point that it'll come around. That's really good.
The reason is because
at this point, I was still amazed that Dr. Liang would let me still go. And I decided to try one more spot. And that seemed to...
So do you see what's different is you're going much slower and you're just kind of letting the vector forces follow instead of just pulling and seeing what comes.
Yeah. And here I probably should have optimized my view a little bit more, but I probably was very excited.
Fair enough.
To not let it go. Try to regrasp in the hope that we're now able to get over the fovea safely.
And this is one of the risks with a very large flap that you still have there, is that you just did the right thing, which is to regrab closer. But if you stay at that leading edge and you have a very long flap that you're pulling, sometimes you're staring at the connection point to the fovea, but the instrument's like on the other side of the eye, and they can get into trouble. So you're regrasping. I think that's very smart.
And there I was off. Finally able to get it off.
Yay.
And then
nice job.
Trimmed a little more, and that's what our end result looked like.
Yeah, whenever you get those little hemorrhages, you always hate it as a fellow or as an attending. You hate it. You look at it. And then the best part is you go back out to wide angle to do scleral depression, and it's like, oh, looks fine.
And then we did
Just means you got a good peel.
Yeah, we made sure that we don't have any breaks, so we did a 360 depression, and we decided to add in some more lasers in the previous retinal tear and lattice degeneration area. And that concludes the case. We decided not to suture. Used 25 gauge here. And this is the post-op week 1. We don't have any additional follow-ups. Vision's 20/50, and the ERM is off the macula.
So then,
Very nice.
Thank you very much.
Great job. That was well done.
Great job.
Super. Hey, Sunil, these were 4 great cases.
Fantastic work. I think you know, we learned a lot from the 4 of you. I think you did awesome, and the faculty are all on multiple antihypertensives now. So congrats. I mean, at least
I would also, if I can also add, you know, for the young trainees out there, you know, it's not easy to show your cases. When you go to conferences, everyone shows like the best case of whatever. So I think we all learn from each other, and you know, I applaud these 4 fellows for showing some of their like very earliest moments in surgery. But I think you know, we all learn from it. So this is hopefully a good environment for everyone to learn together.
Yeah, and this is what the purpose of COBRA is to learn from each other and to educate. So thank you very much, the fellows. Thank you, faculty. Our next COBRA is going to be COBRA in person after dark at AAO. We hope you all can make it. Thanks again to Bausch for their support, and everyone have a great night.